we have an important teaching course regarding liver imaging. We are so glad for your participation, Dr. Jiang. Also, Dr. Lawrence will share us after this lecture regarding artificial intelligence in radiology. Then Dr. Hala Atif will participate us by another lecture regarding artificial intelligence in neuroradiology. Thanks for all. Thanks for our participants. Welcome all. Dr. Jiang, you can start now.
Thank you so much for your kind introduction, Dr. Heshman. And good afternoon, Professor Heshman and my distinguished guests. I am Han Yu from the Department of Radiology with China Hospital, Sichuan University. And it's really a great honor for me to get invited and to meet all of you here. First, I'm going to share some of our experiences in diagnosing hepatocellular carcinoma at imaging. I have nothing to disclose. After participating in today's session, I'd be delighted if you would be familiar with the process of hepatocarcinogenesis and associated pathologic alterations and imaging implications. And second, I hope that we would be familiar with using the liver imaging reporting and data system, LIRIDS, to diagnose HCC in high-risk patients. Next, let's get started with our first learning objective, hepatocellular carcinoma. Okay, so hepatocarcinogenesis. Liver cancer is currently the 6th most common malignancy and the 3rd leading cause of cancer-related death worldwide. And hepatocellular carcinoma, HCC, is the most common form of liver cancer and accounts for around 90% of cases. Chronic HBV, hepatitis B virus infection, and cirrhosis remain the most predominant risk factors for developing HCC, but NASH, associated with metabolic syndrome or diabetes mellitus, is becoming the fastest growing etiology of HCC, particularly in the West. Hepatocarcinogenesis is widely accepted as a multi-step process characterized at the molecular and cellular levels by the progressive accumulation of epigenetic and genetic alterations, and at the histologic level by the emergence and progression of successively more advanced precancerous, early cancerous, and overtly malignant lesions. As shown, multi-step hepatocarcinogenesis is characterized by successive selection and expansion of less differentiated subnodules within more well-differentiated perinodules. The subnodules grow and eventually replace the perinodules. This process can be broadly divided into the cirrhotic nodule or the regenerative nodule here. Low-grade dysplastic nodule, also known as LGDN, high-grade dysplastic nodule, HGDN, early HCC, and progressed HCC. Grossly and microscopically, all regenerative nodules, RN, in a given liver resemble each other, and no RN stands out as benign distinctive from the others. RN lack clonal features histologically, and the cells are phenotypically normal. For these reasons, RNs usually are considered benign. Dysplastic nodules, on the other hand, are nodular lesions usually measuring 1 to 1.5 centimeters in diameter that differ in both macroscopic, for example, size, color, or consistency, and microscopic appearances from the background liver parenchyma. Histologically, LGDN, as we can see here, resembles RN. The hepatocytes show no cytologic atypia, and neither expansile subnodules nor architectural alterations beyond those of RN. Findings that, if present, distinguish LGDN from RNs include unpaired arteries, which we'll talk in detail later, and clonal-like populations, which refers to the aggregate of cells with greater copper, iron, or fat accumulation than the background liver. And these are aspects we will cover in following slides as well. HCDN, by contrast, resemble well-differentiated HCCs. The cells show cellular atypia. For example, the increased nuclear to cytoplasma ratio. Although the atypia is insufficient to establish a diagnosis of HCC and may exhibit clone-like features, architectural alterations, including arrangement of hepatocytes in thin tubercular and pseudoglands, may be present. Expansile subclonal subnodules within varying degrees of atypia may be observed. Clinically, LGDN are considered pre-neoplastic lesions with slightly elevated risk of malignant transformation, while HCDN are considered advanced precursors of HCC with high risk of malignant transformation. Early HCCs are an incipient stage of HCC development, unlike overt progressed HCC, which displaces or destroys the liver parenchyma. Early HCCs grow by gradually replacing the parenchyma. As the cells spread, they surround neighboring portal tracts and central veins, but do not displace or completely destroy these structures. The key distinguishing feature present in early HCCs but not in HGDN is stromal invasion. And eventually, we have progressed HCC here. Progressed HCC, which are overtly malignant lesions with the ability to invade vessels and metastasize. Microscopic and histologic features of this category are variable, depending in part on lesion size. Numerous pathophysiologic alterations accompanying this multi-step hepatocarcinogenesis, among which changes in hepatic arteries, also known as angiogenesis, the portal triads, cellular density, fat content, iron content, and OATP transporters are the most prominent. Let's take a look at each of these alterations one by one. First, angiogenesis is characterized by the presence of unpaired arteries and sinusoidal capillarization. Unpaired arteries are isolated arteries accompanied by bioducts or portal veins. These abnormal arteries are present in RNs, are sometimes present in small numbers in LGDN, and are present with increasing size and number in HCDN, early HCCs, and progressed HCCs. On the other hand, The sinusoidal capillarization refers to alterations in the sinusoidal endothelium, including loss of fenestrate and deposition of a basement membrane that make the sinusoids resemble systematic capillaries. Sinusoidal capillarization is minimal in RN and LGDN and is successively more prominent in HGDN, early HCCs, and progressed HCCs. So angiogenesis gives rise to arterial phase hyperenhancement on contrast-enhanced imaging. In parallel, the portal tracts, which contain portal veins and non-tumoral hepatic arteries, progressively diminish during the multi-step hepatocarcinogenesis, which means the portal tracts are normal in number in RNs and LGDNs and reduced gradually in number in HGDN and early HCCs and virtually disappear in the progressed HCCs. Reduction in portal triads results in the washout appearance on contrast-enhanced imaging. So collectively, these hemodynamic alterations constitute the backbone of most non-invasive HCC diagnostic criteria, namely the washing and washout appearance. So here are some contrast-enhanced ultrasound, computed tomography, and MRI images of typical HCC. As we can see, the mass demonstrate arterial phase hyperenhancement and also portal venous washout, which are attributable to the hemodynamic changes that we have just talked about. So these are other cases of these typical imaging presentation of HCC, namely arterial phase hyperenhancement and portal venous phase washout. Note there is a re-enhancement on the portal venous phase images of this patient, and which is characterized as enhancing capsule, which we will discuss later in the next section. And these are also typical cases and the histologic features of another HCC. Note the prominent arterial phase hyperenhancement, mild portal venous phase washout, and the nodular appearance at pathology. Here is another patient with typical HCC demonstrating arterial phase hyperenhancement, intramass, intralesional arteries, and also washout appearance on the portal venous phase images. During the early phases of hepatocarcinogenesis, hepatocytes may accumulate. The cellular density and nucleus to cytoplasma ratio increases, while the extracellular and intracellular matrix decreases. The nodules also become more distorted in architecture, and these alterations can impede the diffusion of water molecules and lead to diffusion restriction on diffusion-weighted imaging. Also, during hepatocarcinogenesis, hepatocytes may accumulate fat, and LGDN, HGDN, and early HCCs may become more steatotic, either focally within colonal-like subnodules or diffusively than the background liver. The frequency of diffuse intranodular steatosis increase from LGDN to HGDN and then to early HCC. The frequency of diffuse steatosis peaks in the early HCCs and declines with increasing tumor size and grade. Thus, diffuse fatty change is uncommon in large progressed HCCs. It usually is not observed in poorly differentiated HCC. In cirrhotic livers without diffuse iron deposition, iron may accumulate preferentially in LGDN and sometimes HDDN nodules. With further de-differentiation, hepatocytes become resistant to iron accumulation. Therefore, most HDDN nodules in some early HCCs and progressed HCCs are iron-free. Therefore, in diffusively iron-overloaded livers, a solid nodule free of iron is likely to be dysplastic nodules or malignant nodules. Organic anionic transporting polypeptides, the OATP, are a family of proteins expressed in hepatocytes along the basolateral, which is the sinusoidal membrane, and involved in transport of the bile salts. One of these transporters, the OATP8, also known as OATP1, B1, or 3, is thought to be responsible for uptake by hepatocytes of two gadolinium-based contrast agents, including gadoxetate disodium and gadobenate dimethylamine. Emerging evidence suggests that the expression of these transporters diminishes during hepatocarcinogenesis. Expression levels are high in RN and LDN and lower in HDN, early HCCs, and progressed HCCs. Paradoxically, around 5 to 12% of moderately differentiated HCCs and rarely some well-differentiated HCCs overexpress OATP8, likely reflecting a different cell origin or genomic alterations during the multi-step hepatocarcinogenesis. Therefore, OATP8 expression diminishes during hepatocarcinogenesis prior to reduction in the portovenous flow in angiogenesis, making this feature significantly sensitive for detecting minute intrahepatic HCCs. And the expression levels high in RNs and LGDNs, while lower in HDN, early HCCs, and progressed HCCs can aid in differentiation between the latter category of more malignant lesions from the former ones. And these characteristics give rise to the typical feature of HCC, the HVP hypointensity, using gadoxetate disodium enhanced MRI. In summary, among all key alterations that we have just covered, increase in cellular density and reduction in OATP transporters take place in the earliest stage prior to other changes, as we can see here, and are most sensitive indicators of HCC. However, while these changes were valued as major features for HCC diagnosis in some regions, other guidelines treat them as indeterminate ancillary features. After reviewing the key alterations during hepatocarcinogenesis and their associated imaging features, let's move forward to more practice-oriented session. That is to use LIRADS to diagnose HCC in our routine work. And in the end of this section, I will be honored if I could invite some of the audiences to interpret 6 MRI cases using LIRADS. So first, what is LIRADS? The Liver Imaging Reporting and Data System LIRADS is created to standardize the terminology, technique, interpretation, reporting, and data collection of liver imaging in patients at risk for HCC. It was first released by the American College of Radiology in 2011 with major updates and refinements in 2013, 14, 17, and most recently in 2018. We're expecting another major updates of this system in this year. So in patients with increased risk for HCC, each liver observation is assigned with a Lyris category according to its probability of being HCC from Lyris 1 to Lyris 5, non-HCC malignancies, Lyris M, or tumor with vascular invasion, Lyris TIV. So Lyris is used globally as an accurate diagnostic algorithm for HCC with almost perfect diagnostic positive predictive value, that is almost 100%, and specificity. It is fully consistent with and has been integrated into the most recent AASLD 2018 HCC clinical practice guideline as shown here. So let's get started with using Lyris to diagnose HCC. So before start, we need to determine whether Lyris can be applied to a certain patient. Lyris can be applied in patients at increased risk for HCC, namely those with cirrhosis or chronic hepatitis B viral infection or current or prior HCC. But do not apply Lyris in patients without the above risk factors, those less than 18 years old, those with cirrhosis due to congenital hepatic fibrosis, the patients with cirrhosis due to vascular disorders such as hereditary hemorrhagic telangiectasia, Budd-Chiari syndrome, chronic portal vein occlusion, cardiac congestion, or diffuse nodular regenerative hyperplasia. Okay, so after determining whether a patient can be applied with Lyris, the next step of using Lyris to diagnose HCC is to apply the diagnostic algorithm of Lyris. Let's navigate through this algorithm. For an untreated observation without pathologic proof in patients at high risk for HCC as described above, if the observation cannot be categorized due to image degradation or omission, let's assign LRNC. If the lesion is definitely tumor in vein, let's assign LRTIV. Then let's decide if the observation is definitely benign, including those simple cysts, hemangiomas, some focal nodular hyperplasia, and such. Let's assign LR1. If any of these lesions depict some atypical imaging features indicating potential for malignancy, let's do not assign them as LR1, let's get them LR2. Afterwards, let's decide whether an observation is probably or definitely malignant, but not HCC specific. This category may include intrahepatic cholangiocarcinoma, combined hepatocarcinogenesis, and other rare entities of malignancies. Also, we may categorize hepatic metastasis as LRM. After finishing all of these categorizations, otherwise use the CT-MRI diagnostic table, which we will talk about later, and classify those of the remaining observations as intermediate probability of malignancy, LR3, probably HCC, LR4, and definitely HCC, LR5. So let's look at the CT-MRI diagnostic table of Lyris. There are namely 5 major imaging features included in Lyris: arterial phase hyperenhancement, observation size, enhancing capsule, non-peripheral washout, and threshold growth. And the table will allow us to assign a specific observation according to the combination of different imaging features. Let's take a look at each of these major features. First, the observation size. It's important to bear in mind that while we are measuring a liver observation, it's important to include the capsule in measurement and do not measure these imaging feature in the arterial phase or diffusion weighted imaging. It's recommended to measure this in the portovenous phase. Let's have a look at a case. So in this case, we can find a hepatic nodule with arterial phase hyperenhancement and washout appearance in segment 8, this patient. Note that in the arterial phase, the nodule seemed to be bigger, while in the pre-contrast and delayed phase, the nodule became less well appreciated. So it's better to measure the lesion size on the portovenous phase images. So do not measure in AP or DWI, most commonly in PVP. Non-rim arterial phase hyperenhancement, non-rim FE. It's really important to bear in mind that for T1 hyperintense lesions, it's better to use the subtraction imaging with co-registration to identify the true hyperenhancement from those which may have been masked by the hyperintensity on T1 weighted images. Timing of the arterial phase image is really important. The optimal arterial phase images are acquired usually 35 seconds after injection of the contrast media. And on that image, we can see that the hepatic arteries and portoveins enhance brightly, whereas the hepatic veins do not. If suboptimal arterial phase images were acquired, it's better to repeat MRI or use multi-arterial phase imaging for better AP timing, or just transform to other imaging modalities, for example, the contrast-enhanced ultrasound or contrast-enhanced CT. If the nodule enhances in part, including nodule-in-nodule morphology or intratumoral arteries, or entirely, both of these categories can be assigned as non-rim FE. Let's look at this patient with a T1 hyperintense nodule on the pre-image. And after contrast media injection, it's really hard to say whether it is really enhanced or not. But after applying the subtraction imaging, we can realize that the whole nodule area does not depict any hyperenhancement in relative to the surrounding liver parenchyma. So it's better to say that this patient does not have any non-rim FE. So subtraction imaging is recommended for T1 hyperintense lesions. And this is a case with bad AP timing. Note that the aorta is enhanced here and the hepatic arteries are enhanced here. But look at the portoveins. None of the portoveins enhances on this image. So this could be better appreciated as early arterial phase rather than the late arterial phase that we frequently use in HCT diagnosis. So let's repeat this again. The optimal arterial phase images are acquired when the hepatic artery, the portal veins enhance brightly, while the hepatic veins do not. Okay, so non-peripheral washout. Non-peripheral washout should be appreciated on portovenous phase, delayed phase, in relative to the background liver. So for the PVP hyperintense lesions, which enhance less pronounced than AP, is not washout. And just like the same scenario that we encountered for non-RIP FE, for T1 hyperintense lesions, it's recommended to use subtraction imaging to evaluate the real washout on the portovenous phase. For patients with severe steatosis or iron deposition, it's better to use additional CT, CUS, MRI with sequence optimization, including in-phase echo times without fat set, and shortest possible TE for better washout appearance characterization. And FE is not required to evaluate the presence of washout. So look at this patient. This is the pre-contrast images of this patient with chronic hepatitis B virus infection. And B refers to the anterior face images, while C is the portovenous face image. Look at the nodule enhances avidly on the anterior face images, but it's still hyperintense in relative to the surrounding liver parenchyma on the portovenous face images. So it's not appropriate to assign washout for this patient. So no washout relative to the background liver. Let's move to enhancing capsule. Enhancing capsule is a major imaging feature usually evaluated on portovenous phase, delayed phase, or transitional phase images. Do not evaluate this feature on the arterial phase images. It's important to differentiate this feature from non-enhancing capsule, which is frequently evaluated on the pre-contrast T2-weighted, HBP, or diffusion-weighted images. This feature might be challenging to detect using hepatobiliary phase contrast agent enhanced MRI because the early hepatocellular uptake of the contrast agents may cause the surrounding liver to enhance substantially in the portovenous phase and transitional phase, which may obscure a real capsule. Let's have a look at this typical case. So on the pre-contrast phase, we can see a rounded nodule with thin and uniform rim hypointense areas, and those areas enhances on the portovenous phase and keep enhancing on the transitional phase images. So this is an enhancing capsule. Then let's move to ancillary features. Broadly, ancillary features in LIRAS can be categorized as ancillary features favoring malignancy and those favoring benignity. Among the first category, the ancillary features can be further divided into those favoring malignancy in general, but not HCC in particular, and those favoring HCC in particular. In the following slides, I will delve into restricted diffusion, mild to moderate T2 hyperintensity, corona enhancement, transitional phase hypointensity, hepatobiliary phase hypointensity, non-enhancing capsule, in nodule appearances due to their clinical relevance and relatively high prevalence in liver imaging. So first, restricted diffusion. The definition of restricted diffusion is increased signal intensity at diffusion-weighted imaging, not attributable solely to T2 shine through, higher than and or ADC lower than the liver parenchyma. There are some technical points that we should apply before evaluating this imaging feature. At least low p-values, which is less than 50, and high p-values over 400 should be used in diffusion-weighted imaging. And the underlying mechanical underpinnings of these features includes increased cellular density and nucleus to cytoplasma ratio, decreased extracellular and intracellular matrix, and these two collectively will lead to the water molecule diffusion restriction. We can look back a little bit and remember
Yes.
All right, I am back. Hi, Professor Hirschman. Okay, so is it okay for me to share my screen right now? All right, let's see. Okay, right, share my screen. Okay, I guess I am back. Thank you. Thank you for waiting. All right, so let's review a little bit on this slide in case that any one of you just get logged out from the session. And so restricted diffusion is increased signal intensity at diffusion-weighted imaging, not attributable solely to T2 shine through higher than and or ADC lower than in liver parenchyma. At least one low p-value less than 50 and one high p-value over 400 are recommended. The underlying mechanism of these imaging features, as we can remember from the ones that we have just talked about in hepatocarcinogenesis, the cellular density and nucleus to cytoplasma ratio increase during hepatocarcinogenesis, and the extracellular matrix and intracellular matrix decrease during this process. These two collectively lead to the restricted water molecule diffusion, and these altogether result in restricted diffusion on DWI images. Okay, let's move to mild to moderate T2 hyperintensity. Mild to moderate T2 hyperintensity refers to the T2 weighted image signal intensity mildly or moderately higher than that of the liver and similar to or less than that of the non-iron overloaded spleen parenchyma. As we can see from the case here, the mass demonstrate mild to moderate T2 hyperintensity in relative to the liver and to the spleen. So unlike other features which we focus on the liver parenchyma and the observation solely, for the evaluation of these imaging features, we need to look at not only the liver observations, but also the liver parenchyma and the spleen parenchyma. And the underlying mechanisms for the development of these imaging features, including increased intratumoral dilated sinusoids, increased edema, and watery fibrosis. Corona enhancement. Corona enhancement is defined as peri-observational enhancement in late arterial phase or early portovenous phase attributable to venous drainage from the tumor. The underlying mechanism for this imaging feature includes the venous drainage of contrast material from the tumor into the peritumoral parenchyma, sinusoids, and the portovenues, and the aberrant and disorganized venous drainage develops during hepatocarcinogenesis owing to the occlusion of intranodular hepatic veins. Transitional phase hypointensity. Transitional phase hypointensity refers to the signal intensity and the transitional phase unequivocally less in whole or in part than the liver. There is also a technical point that I hope that we can bear in mind before applying or evaluating this imaging feature. That is, after the hepatobiliary phase contrast agent injection, we can acquire the transitional phase images around 3 to 5 minutes after injection. And on the optimal images of transitional phase, the liver vessels and the hepatic parenchyma are of similar intensity, as we can see from the image here. On these slides, we are anticipated to observe the hepatic veins, but we cannot see it. Rather, the hepatic veins are of similar signal intensity as the surrounding liver parenchyma. So this is a typical transitional phase images of a patient with hepatocellular carcinoma. The underlying mechanism of transitional phase hypointensity includes true washout secondary to the reduction in prototriads, as we have discussed previously, in hepatocytes uptake of the contrast agent. So it's important for us to understand that these contribute to the limitation that for the hepatobiliary contrast agent enhanced MRI, washout appearance can only be appreciated on portovenous phase images. But for the extracellular contrast agent enhanced MRI, we can evaluate Thank you. Oh, sorry, but I am unable to. Oh, yeah, here we go. All right, seems we are back again. Okay, so let's go back to transitional phase hypointensity. As we have talked about earlier, it is constituted with, so two compositions, including the true washout and hepatocyte uptake of the contrast agent, contribute to the appearance of transitional phase hypointensity. So it's limited to, so we should strictly evaluate the washout appearance on portovenous phase images for hepatobiliary contrast agent enhanced MRI, but we can evaluate the washout appearance on both portovenous phase and delayed phase images for extracellular contrast agent enhanced MRI. HBP hypointensity, hepatobiliary phase hypointensity, it is defined as the signal intensity in the HBP less in whole or in part than the liver. The technical points for this appearance includes that we can acquire the HBP image for EOB at 20 minutes or later, while 1 to 3 hours with BOP-TA. The underlying mechanism of this imaging feature, as we have talked about earlier, is the reduction in OATP transporter expression during the hepatocarcinogenesis. Non-enhancing capsule. Non-enhancing capsule is defined as capsule appearance not visible as an enhancing rim. It can be attributable to either a real capsule, which is the histological capsule, or the pseudocapsule, which can be perilesion sinusoids, fibrous tissue, compressed liver parenchyma, peritumoral liver parenchyma injury due to hypoperfusion, and etc. Nodule in nodule architecture. Nodule in nodule architecture is the presence of randomly distributed internal nodules or compartments, usually with different imaging features inside a parent nodule. The underlying mechanism for this ancillary feature favoring HCC in particular is the characteristic histologic growth pattern of hepatocarcinogenesis. That is, the morphologic D differentiation and clonal multiplication of less differentiated cells in the inner nodule, replacing the well-differentiated or dysplastic outer nodule. We can see from the graphical illustration here, the colored cells indicate the more malignant cells, whereas the yellow ones indicate the less and more differentiated hepatocytes. And this feature usually is not present with other malignant tumors, such as ICC, CHCC, or metastasis. So this is an imaging feature which is highly specific for HCC. And the underlying mechanism is largely attributable to its multi-step hepatocarcinogenesis. Here is a case of typical nodule-in-nodule architecture. The first image is the image of the opposed phase, and the second is the pre-contrast T1 weighted imaging, the arterial phase imaging, the portovenous phase, HVP, and diffusion weighted imaging. We can see that within the outer parent nodule, there are two inner nodules which depict different imaging features throughout different each phase of the imaging. So this is a patient with nodule-in-nodule architecture. Okay, after the first step and the second step, the first step, let's review it. And due to the technical issues, I think it's better to review the first step and the second step. So the first step is to apply the major features and using the diagnostic algorithm to assign a Lyris category to a given observation. The second step is to apply optionally the ancillary features and adjust the category assignment. The third step is to apply the tie-breaking rules if needed. There are two major compartments regarding the third step. The first one is regarding the TIV category, while the second is regarding other categories. So let's look at the TIV category first. If we are unsure about the presence of TIV, we do not want to categorize as a TIV. And let's take a closer look at what is a TIV tumor in vein. That is unequivocally enhancing soft tissue in vein, regardless of visualization of parenchymal mass. And we probably want to underline the enhancing soft tissue in vein. Let's look at this patient. We can see that there is unequivocal enhancing soft tissue in vein. So this patient can be assigned as LRTIV. But let's look at this patient. There is a hypointense hepatic mass in the segment 2 and 3 of this patient. And the mass is continuous with the left portal vein. And so it shows the imaging appearances suggestive of tumor in vein, including occluded vein with ill-defined walls, occluded or obscured vein incontinuous with malignant parenchyma, but there is no unequivocal enhancing soft tissue in vein. So it's better not to assign LRTIV for this patient. The second compartment of step 3 is adjusting the category assignment between two different categories. That is, if you are unsure or uncomfortable between two categories, choose the one reflecting lower certainty of HCC. So for LR1, 2, and 3, the lower certainty of benignity decrease as the category increase, while for LR4 and 5, the certainty increase as the category increase. And while for LR5, 4, and M, LRM demonstrates a higher uncertainty of HCC and should be assigned when we have problem differentiating between these two categories. Let's have a look at a case here. So for this case, we may want to say it's rim-aphy or it's it's peripheral washout, but we are not quite sure. If the patient is evaluated for rim-aphy, that the patient should be, that the observation should be assigned as LRM. But if we assigned non-rim-aphy for the observation, it's probably an LR5 observation. But remember, when we are unsure between two different categories, it's better to assign the one with lower certainty of hepatocellular carcinoma origin. So let's assign it with LRN. And this observation is histopathologically confirmed as an intrahepatic cholangiocarcinoma. Okay, so let's get some practice with 6 cases. So this is a section that I would like to invite some audiences to participate. Is it okay for me to invite the audiences here? Okay, then let me keep up with these cases. For this patient, this is a 1.9 centimeter nodule found in the segment 4 of, okay, so Professor Mohammed wants to say something about this case. Thank you. Do I need to stop sharing? Oops. Okay. Are we expecting some answers from Professor Mohammed? If not, then let's just keep going with these cases. So this is a 1.9 centimeter nodule found in the second floor of a patient with hepatitis B virus related cirrhosis. We can see from the picture here, the images here, the nodule is located at the bifurcation of the portal veins. It is hypo-intense on T1 weighted images. It demonstrates non-rim-aphy on the arterial face image, mild washout on the portovenous face image, and an enhancing capsule. It is hypo-intense in the transitional phase, hepatobiliary phase, and it demonstrates mild to moderate T2 hyperintensity. On diffusion weighted images, it demonstrates diffusion restriction using a B-value of 1200. So let's look at the diagnostic table. First, we can navigate through non-rim-aphy and observation size. So the patient would be located here for these 3 different cells. And then we can appreciate, because the patient has, the observation has non-peripheral washout. And note that this cell is subdivided into 2 cells. So for the first one, if the patient presents with enhancing capsule, then the observation would be better assigned as LR4, while if non-peripheral washout or threshold growth is present, the observation can be assigned as LR5. So this is an LR5 lesion. Okay, so let's see. Yeah, great. Great job, Islam. Okay, let's have a look at the second case. It's an 1.9 hepatic nodule found in segment 2 of a patient with chronic hepatitis B virus infection. So on the pre-contrast T1 weighted images, the nodule appears mildly hypointense. It demonstrates non-rim aphy and portovenous phase washout, enhancing capsule, mild to moderate T2 hyperintensity, HBP hypointensity, and diffusion restriction. So let's go back to the diagnostic table. So first, non-rim aphy, 10 to 19 millimeters in size, non-peripheral washout, and LR5. Okay, so this is another case with 9.5 centimeter mass in segment 6 and 7 of a patient with chronic hepatitis B virus infection. Okay, so the mass demonstrates hypointensity on pre-contrast T1 weighted images and intranodular hemorrhage, which is the blood products in mass, according to Lyra's ancillary features. On arterial phase images, the mass became hyper-enhanced, so non-rim aphy. On the portovenous phase, I think it is hypointense in relative to the surrounding liver, so it's probably non-peripheral washout. On T2 weighted images, it's mild to moderately hyperintense, and on HCP images, it is hypointense. It also demonstrates diffusion restriction on diffusion weighted images of B values 1200. So it's over 20 millimeters in diameter. Two other major features, including enhancing capsule and non-peripheral washout. So it's an LR5 observation. Here's another case. This is the case that we have just showed for the washout appearance. So on the pre-contrast T1 weighted images of this patient, a 2.5 centimeter hepatic nodule is found in segment 6 and 7 of a patient with chronic hepatitis B viral infection. The observation became hyper-enhanced on arterial phase images, but the enhancement continues on the portovenous phase images, and so no washout. The observation demonstrates mild to moderate T2 hyperintensity, hepatobiliary phase hypointensity, transitional phase hypointensity, and diffusion restriction. So let's look at the diagnostic table. Over 2 centimeters in diameter, non-major features, because there is no enhancing capsule nor non-peripheral washout. So this is an LR4 observation, regardless of the presence of several ancillary features, including hepatobiliary phase hypointensity, mild to moderate T2 hyperintensity, the restricted diffusion. Those ancillary features are unable to upgrade an observation from LR4 to LR5. So this nodule remains an LR4 observation. However, this nodule is histopathologically confirmed as an HCC. These are the contrast-enhanced images of another patient with chronic hepatitis B virus infection. So on the pre-contrast images, we can see that the mass is mildly hyperintense. It demonstrates avid aphy on the arterial phase images, mild washout on portovenous phase images, hypointensity in the transitional phase, and hyperintensity on the HBP phase. Remember that we have we have said around 5 to 12% of the HCCs can present with OATP1B3 overexpression, and those HCCs will be categorized as categorized as having HBP hyperintensity. We may find these observations difficult to be differentiated from the focal nodular hyperplasia FNH. So it's important to evaluate other sequences, because for FNH, the portovenous phase and transitional phase images of the mass should be hyperintensity in relative to the surrounding liver. But for this patient, the observation appears hypo intense on the HBP phase and TP phase. So it's more likely to be an HCC instead of a FNH. And the IHC staining also reveals that the OATP1B3 transporter on the cell membrane of the tumor cells are overexpressed. So for this patient, over 2 centimeters in diameter with non-rim aphy, and over 2 additional major features. So this is an LR5 observation and also an HCC. This is another patient with a 1.8 centimeter nodule found in S7 of a patient with chronic hepatitis B infection. So on the pre-contrast T1 weighted images, we can see that the nodule appears mildly hypo-intense in relative to the background liver. The observation demonstrates non-rim aphy, controversially portovenous washout, enhancing capsule, mild to moderate T2 hyperintensity, restricted diffusion on diffusion weighted imaging, and paradoxically HBP hyperintensity. So this is 1 to 1.9 centimeters in diameter, non-rim aphy, enhancing capsule or non-peripheral washout, and non-peripheral washout. So this is also an LR5 observation. So in the end, I would like to sum up the take-home messages that we might have learned from today's session. So hepatocarcinogenesis is a multi-step process involving key alterations in angiogenesis, phototrias, cellular density, fat content, iron content, and OATP transporters, each with associated characteristic imaging implications. LIRIS is widely used diagnostic algorithm in HCC at-risk patients, and understanding the biological underpinnings of each LIRIS feature is critical for feature identification and avoiding misinterpretation. Thank you so much for your attention for this session. And so in the, I wonder if we are expecting any questions from the audiences here.
Thank you very much, Dr. Hanyu, for this very important lecture. Dr. Muhammad, Dr. Fauzi, how are you?
Hi.
Morning, Dr. Zing. Sorry, because I'm now in the States in Chicago, and it's 5:30 a.m. in the morning.
Oh, I'm sorry.
But I could not miss this session, definitely.
Thank you so much.
Because I really believe in LIRADS, and I think actually back home in Egypt, the implementation of using LIRADS in all our reports is not done yet. Actually, I believe the very few people are implementing it now. But with the growth rate and the effort that's being done, like with Professor Hisham, that we are orienting people more with the real use of LIRADS. Because actually, to tell you the truth, some clinicians do not believe in LIRADS.
Oh.
Yes, they still are controversy about it, and they prefer directly to go for biopsy. My question is, where is the biopsy in this?
Thank you so much for your question, and thank you so much for your comment. I really hope that you can enjoy your trip in Chicago. So thank you again for the question. We rarely perform biopsies in our institution, but if we are considering a patient, an observation is assigned as LR4 or LRM in accordance with the AASLD HCC practice guideline. Those observations are recommended to undergo biopsy. But it's more the case in China that for those observations, we would prefer just resect them or just use radiofrequency ablation to treat those lesions, because those lesions are considered high risk, and the patients are most commonly having a strong intention to treat their liver nodules. So we rarely perform biopsies for those lesions. Rather, for some end stage, like for BCLC B or C stage cases, those patients we would sometimes treat them with like the systematic therapies, and we, with accumulating evidence suggesting the molecular subclasses of HCC, we want to have some more pathologic information regarding those HCCs, and sometimes we will perform biopsy for those.
Biopsy.
Yeah, that's more for the systematic therapy purpose. But if the patient is within the is still considered as good surgical candidates, we would rather just do the resection and do not biopsy those patients. The surgeons are more straightforward.
Yes, I know. So the surgeons are straightforward, that they like direct go to treatment, whether it's intervention or surgical. Because now the role of intervention is growing more and more in comparison to the surgical. So, but I'm talking from the hepatologist point of view. And any equivocal lesion on the LIRADS, they usually prefer to go to biopsy. I personally, I go more for non-invasive. This is my my legacy. I believe more in non-invasive. But from your work, using LIRADS and then surgery and then pathology.
That's right.
Were there lesions? Were there lesions that were missed?
That's another great question. So from our experiences, it's the sensitivity of LIRADS is not as satisfactorily high, because it's more for our patients, they usually have less advanced cirrhosis, and more patients are surgical candidates, or we want to have initiate earlier treatment for the liver observations. I think this scenario is a little bit different from the Western world, where liver transplantation is the mainstream curative treatment option. So we value sensitivity more than specificity in some settings.
Okay.
And in this case, like if we are to use LIRADS to diagnose HCC, around 30% of HCCs will be will not be categorized as LR5. That's why the surgeons and they will perform resections for the LR4 lesions, because those lesions are very likely to be misdiagnosed by LIRADS. Say those sub-centimeter lesions, many of them can be HCC, but they will just be assigned as LR4 according to LIRADS. And there is another thing, which is if there is a lesion which is categorized as LR4, but if we think it's really high risk, we will perform CUS, contrast enhanced ultrasound. And ultrasound can really aid in the characterization of these indeterminate lesions. And around half of these lesions can be upgraded to LIRIS 5 after the CUS examination. Altogether, around 30% of the HCC cases would be diagnosed as for LIRIS 4 or LIRIS M in our practice. And after applying CUS, half of these observations can be correctly categorized as LR5, but there's still around like 15%, which we can never achieve before surgery.
Thank you very much.
Thank you.
There's a question from Islam.
Islam?
There is a question from Islam Zaki. He's asking, do you always use hepatobiliary specific contrast for all the HCC surveillance? What is the imaging recommendation for nodule in nodule after establishment of dysplastic HCC nodule?
Okay, thank you. Thank you, Islam, for your very, very good question. For the hepatobiliary phase contrast agent, we don't use it as a surveillance tool. It's more like a diagnostic tool. For surveillance purpose, ultrasound and contrast enhanced CT are the mainstream surveillance tools coupled with AFP. So the serum tumor markers, AFP and PIVCA2, together with ultrasound and contrast enhanced CT are the mainstream surveillance tools for high-risk patients, whereas the contrast extracellular contrast agent enhanced MRI and hepatobiliary contrast agents enhanced MRI are considered as the diagnostic tools for HCC. Some of the HCCs can be confidently diagnosed with CT. For those cases, the doctors will prescribe hepatobiliary contrast agents, enhanced MRI for better staging purposes to identify minute intrahepatic metastasis of the mother nodule. But in addition to these purposes, the hepatobiliary contrast agent enhanced MRI is not that widely used as contrast enhanced CT or extracellular contrast agent enhanced MRI in our practice. So I think that's the first question. May I know the second question regarding nodule again? It's weird, I cannot read the question.
He says, what is the imaging recommendation for nodule in nodule after establishment of dysplastic HCC nodule?
Yeah, we will resect those nodules. We'll not wait. If a definite HCC diagnosis is achieved in our practice, the clinicians or the surgeons will most frequently suggest the patient to undergo hepatectomy and sometimes liver transplantation, but that's very rare cases. Hepatectomy and sometimes TACE are the mainstream treatment options for the patients in our institution.
Well, actually, in Egypt now, liver transplantation is considered the primary treatment modality, actually, and it's growing month after month, and the number of cases are growing, especially when cases with HCC. But because I work in the liver transplant program, having cases, we do pathology post-liver transplant. And I think maybe we did a study a few years ago that we found maybe 5 or 8% of the cases that were diagnosed HCC prior to the transplant, when the explant is taken, they were not HCCs.
So what kind of nodules are them?
This plastic.
Oh, it's
We
plastic.
we don't go to low grade or high grade actually in pathology here yet. Also, and this is a very nice categorization. Actually, I'm impressed with it. So we go more for liver transplant as the primary modality, putting in mind the patient is within Milan criteria. But large HCCs, of course, we have to downstage and we have to wait for them.
Yeah.
No, I wanted to ask you, do you have to do both modalities for each patient, or usually use one modality, CT or MRI?
That's another very great question. So
because you know this is costly.
Yeah, mostly we just do contrast enhanced CT for the patients. But if we are to achieve better staging, or so I think the scenario can be divided into several different sections. So for the patients which are confidently diagnosed for HCC at CT, the MRI is more for staging purpose. If the nodule is small, like less than 3 centimeters or even less than 2 centimeters at BCLC 0, we can confidently just use CT for the preoperative imaging modality. But if the patient, the observation is relatively big or some aggressive imaging features like infiltrative appearances or the perilesional hypo enhancement on portovenous phase, or we suspect that there might be minute small intrahepatic lesions, metastasis from the nodule, it's better to. So that's for diagnosis and for staging. I think around 20 to 30 patients with HCC in our institution will undergo MRI prior to surgery.
Okay.
Yeah.
So 20% to 30% of the patients will be transferred for MRI.
Yeah. But CT is like a baseline. Almost all patients will undergo CT. And if the observation is indeterminate on CT or the staging is somewhat controversial, we will then suggest the patients to undergo MRI. Yeah.
My question is now, if you have a walk-in patient, known liver cirrhosis, HBV, HCV, and you find the nodule in ultrasound on his routine ultrasound, and it looks like HCC in the ultrasound, you need to do a contrast study. Why not proceed directly for MRI? We are starting to implement this. Not for staging, but for diagnosis even.
If the nodule appears typical HCC ultrasound, is that just a Doppler
Not
ultrasound?
typical, not a typical, a suspicious. Please.
Okay, a suspicious. Then it's better to do MRI directly. The information.
Because you always do a CT. You always do a CT for a patient who has a.
Not necessarily.
Why do you do a CT?
Not necessarily. Because our center is a referral center. If the patient already have some CT examination at like lower grade hospitals, we can do MRI directly, bypassing CT. But if the patient did not have any prior examinations outside of our hospital, some surgeons will still prefer to prescribe CT for the patients. It's much cheaper and it's faster for a patient, because our hospital is a very high volume hospital in China. Generally, for a patient undergoing CT examination, the waiting period would be around 2 weeks.
Sure.
Yes, while for MRI, that would be 2 months.
Wow.
That's a very big difference.
You have a lot of big volume overload.
Yeah, we are over flooded, overworked.
But you're doing great work on on LIRADS or liver imaging. Great work, very respectful work.
Thank you so much. That's really a pleasure.
Professor Hisham.
Thank you very much, Dr. Anio. Thank you very much, Dr. Muhammad. Dr. Anio, we hope that we'll meet again many times in our teaching sessions for our department. In the future, we'll arrange more lectures soon, maybe next week after the first half of December. Always you are welcome, Dr. Anio. Thank you very much for this an interesting lecture. Thank you very much, Dr. Muhammad. Now we'll start with Dr. Hala Atif regarding artificial intelligence in neuroradiology. Dr. Hala.
Thank you. Thank you all.
Good afternoon, ladies and gentlemen. It's a great honor for me to be among you today. And I would like to thank Dr. Hisham Sheikh for his kind invitation. My topic is about artificial intelligence in neuroradiology. My agenda composed of definitions, promising clinical applications of AI in neuroradiology, applications of AI in glioma imaging, a novel system for precise glioma grading, sorry for interruption. حاضر. تمام. My agenda composed of definitions, promising clinical applications of AI in neuroradiology, application of AI in gliomas, a novel system for precise glioma grading, challenges against AI and deep learning, precision medical education, and the future role of radiologists in AI world. First, I propose to consider a question: can machine think? The answer is yes, if we use AI or artificial intelligence. Artificial intelligence is a broad term composed of contain machine learning and deep learning. Artificial intelligence means the computer ability to perform tasks that are similar to those performed by humans. Intelligent machines will replace the human capabilities in many areas, especially in radiology field. Machine learning is a study of computer algorithms that allow computer programs to automatically improve through experience. Deep learning depends on artificial neural network, which is a mathematical representation of the human neural architecture. As we see here, this is the neuron of the human brain, and this is the perceptron of the artificial neural network. Deep learning depends on artificial neural network, which is composed of input layer and multiple hidden layers and output layer. Artificial intelligence has the ability to perform three main clinical tasks: detection for localization of objects of interest in vertebrates, characterization for segmentation, diagnosis, and staging of the tumors, monitoring to monitor changes in the tumor over time and response of treatment. Please mute all participants, please. Okay. What is the CAT system? The CAT system is a computer-aided detection for detecting and locating the abnormal area, computer-aided diagnosis for diagnosis and classify benign or malignant tissues. Promising clinical application of AI in neuroradiology include classification of abnormalities, detection of the lesion, such as intracranial hemorrhage, stroke, multiple sclerosis, and intracranial aneurysms, Neuro-Oncology and Metastasis. Classification of abnormalities such as hemorrhage, infarction, may affect detection of the lesion, such in intracranial hemorrhage, stroke, multiple sclerosis, and intracranial aneurysms, neuro-oncology, and metastasis. Prediction of the outcome, such in predicting final stroke volume, predicting tumor type and prognosis, post-processing tools such in brain tumor volume quantification, multimodal integration, for example, in MS, epilepsy, and Alzheimer's disease, image reconstruction. It has role in image enhancement by reduction the noise and give us a super resolution image, increase the workflow by automate protocol choice and optimize scanner efficiency. Patient safety, and it has a major role in patient safety and quality improvement, reduction the recall rate, and it has a major role in precision medical education. In intracranial hemorrhage, it has been widely studied as a potential application for deep learning. It includes triage, early warning systems, double reading, and hemorrhage type classification. Kerr et al. Developed a 3D convolutional neural network model to detect 4 types of intracranial hemorrhage, such as subarachnoid, acute intracranial hemorrhage, intraparenchymal, and brain polytrauma hemorrhage. Approved commercial software for hemorrhage detection now available. In stroke, deep learning in stroke imaging continues to be an area of active research. 3 components of stroke imaging are explored. First, automated measurement of Alberta stroke program, early CT score, which is called aspects, large vessel occlusion detection, and infarction prognosis. Aspects is an important early predictor for ischemic strokes. It assists in regions within the MCA territory for early signs of ischemia. The score range from 0 to 10, where 10 indicate no early signs of ischemia, while 0 indicate ischemic involvement of the whole 10 regions. The score is currently a key component in the evaluation for endovascular thrombectomy. Several commercial offers which perform automated aspects evaluation have been assessed in clinical settings. As we see here, this is a 74-year-old woman with right-sided stroke due to M1 occlusion. Two neuroradiologists assist her aspect of 8 in the initial CT image, but rapid aspect software evaluation gave her score 4. The patient subsequently underwent a thrombectomy. On day 3, post-admission aspect evaluation was 3. This shows that better agreement with initial assessment by the software. In multiple sclerosis, MRI play a golden role in the management of MS. This requires comparison with previous scan, which carry risk of mistakes when the number of the lesions is large. Deep learning has been investigated as a tool to estimate disease burden and to predict disease activity. In intracranial aneurysms, they are the most common cause of non-traumatic subarachnoid hemorrhage. Time of flight MR angiography is the modality of choice for aneurysm screening. Deep learning has been used to detect aneurysms on time of flight MR angiography. Published data demonstrate high sensitivity but poor specificity, resulting in multiple false positive results. As we see here, automated aneurysm detection on time of flight. Number 1 indicate the highest probability to be an aneurysm. Number 3 indicate the third highest probability. But actually, in A here, number 1 is a true positive, but number B is a false positive. In head and neck imaging, machine learning has been used to aid segmentation for tumor and normal structures. This has value in radiation oncology, as squamous cell carcinoma in head and neck often is a good radiation candidate. In spine, multiple applications of deep learning and machine learning have been evaluated. This includes vertebral fracture detection, vertebral body segmentation, and scoliosis quantification. As we see here, this is a model for segmentation output showing the vertebral bodies in green, intervertebral discs in red color, and the spinal canal in yellow, the sacrum in blue color. Contours of the segmented region allowing for signal intensity measurement to be taken. Multimodal integration is combining multiple imaging modalities, improve clinical diagnosis, progression tracking, and prognosis prediction. Ongoing studies aim to apply similar models trained on multiple forms of data. As we see here, this is a multimodal integration model for MS case. We collect the imaging data. As we see here in this FLAIR image, we show area of increased signal intensity with subtle post-contrast enhancement. We collect this imaging data besides the clinical data of the patient and the laboratory data as clonal bands in electrophoresis. All this data are fed in the input layer of the artificial neural network. This information passes through multiple hidden layers to get from the output layer and give us the final diagnosis as MS case. Another example for multimodal integration in a case of epilepsy, the image data tell us that there is high signal intensity in the hippocampal region with the atrophy. And beside the hypometabolism in the temporal lobe in the PET scan and ictal waves in the EEG, besides the information from the seizure semiology, all this data fed in the input layer to give us the final diagnosis as medial temporal sclerosis. Also, it gives us a prediction for treatment response, either for anti-epileptic medication or for surgical resection. The third case for multimodal integration in Alzheimer's disease is the genetic information besides the PET information and MRI information and cognition information. All this get in the input layer to give us the diagnosis of Alzheimer's disease and predict the progression of the case. What about image enhancement? Look at these two images. Which one look to be with better enhancement? Yes, this is with better enhancement. This image is deep learning based image reconstruction model. Achieves a high quality brain MRI images compared to the standard image. Here, a deep learning based model used to generate diagnostic quality post contrast MRI image using the ultra dose of gadolinium. Here is a conventional MRI image with the maximum dose of, or the standard dose of contrast media. And here is the conventional image with the lowest dose of gadolinium. But here it is deep learning based image, give us better enhancement using the lowest dose of contrast media. What's the application of AI in gliomas? It includes grading, tumor segmentation, predicting glioma grading, predicting glioma genomics, preoperative planning, intraoperative treatment planning, histopathologic diagnosis, radiotherapy, post-treatment follow-up, and outcome prediction. A novel system for precise grading of glioma. Our work was done at Radiology Department, Mansoura University, under supervision of Professor Lamia El-Srougi, Head of Radiology Department, and lead Professor Ahmed Abdel Khalek, may God bless his soul, in collaboration with Bioengineering Department, Lowell University, under supervision of Professor Ayman El-Baz. Annually, from 5 to 10 per 100,000 people are in danger of contracting glioma. It represents 30% of brain tumor. It is the 10th leading cancer cause of death in USA. It has median survival rate less than 15 months, and its 5-year survival rate less than 10%. WHO classification of glioma include grade 1 and 2, which consider low-grade glioma, and grade 3 and 4, which considered high-grade glioma. The current diagnostic tools include biopsy, which is the gold standard, MRI, advanced MRI submodalities such as diffusion, perfusion, spectroscopy, and PET MRI. The study was conducted in a total 99 pathologically proved glioma classified as follows: 13 patients with grade 1, 22 patients with grade 2, 22 patients with grade 3, and 42 patients with grade 4. Conventional MRI protocol was done for all patients, include pre and post T1 weighted image, flare, and diffusion weighted image. Segmentation was done for the tumor only in T1A and the diffusion image, and the tumor with the surrounding edema in flare images. Here, our proposed GG-CAD framework. It includes 3 main steps. First step is glioma tumor pre-processing. We choose diffusion image, flare image, and contrast enhanced image. Then we did the proper segmentation for the tumor and construct a 3D glioma objects. From these 3D objects, we extract the features in the step 2, which is feature extraction and selection. We extract morphological, texture, and functional features. All this information and features extracted are fed in the input layer of the artificial neural network in step 3 to give us the final diagnosis from the output layer and classifying glioma into 4 grades. First step, which is glioma tumor pre-processing, the more accurate the segmentation, the more precise feature extraction will be. Binary masks were applied over the gray level DICOM image to construct the 3D objects. These 3D objects are then used for extracting features. Feature extraction include texture, morphological, and functional features. First order texture extraction give precise description for the heterogeneity and homogeneity of the detected glioma. Second order gray level co-occurrence matrix accounts for how frequently a pair of gray level intensity values appear adjacently within the object. Second order gray level run length matrix examines how many times each gray level value appeared successively in a run of voxels. Morphological feature extraction based on 3D histogram of oriented gradient and estimating the glioma volume. It relies on the hypothesis that gliomas with high grade have more aggressive growth rate, more complex, rough, and irregular shapes than those with lower grades. Functional feature extraction by estimating voxel-wise apparent diffusion coefficient and washing slope. As we all know that functionality of gliomas has effect on the imaging. Feature integration and classification, aforementioned individual features then integrated together to be fed to a multi-layer perceptron artificial neural network classification model toward getting the final diagnostic decision. Results and conclusion, the proposed GG-CAD system achieved high overall accuracy, results hold a promise for the developed GCAD system as a non-invasive diagnostic tool. It has many advantages in comparison to previous studies. These advantages include precisely identify glioma into 4 grades instead of low grade and high grade, functional feature incorporated for a better diagnostic performance, the first system to integrate novel 3D appearance features, volumetric features, 3D texture feature, and functional features extracted from the multimodal MRI images. What is the challenges against deep learning and artificial intelligence? False positive rates remain a major barrier to its wide use. The system is almost completely incapable of providing an explanation for its diagnosis. Implementation in radiology practice has legal and ethical challenges. Who will be responsible for the mistakes that computer will make? Patient acceptance or non-acceptance for the human not being involved in the process of interpreting their images. How to incorporate deep learning algorithms into the radiology workflow in order to improve rather than disrupt the radiology practice. Precision medical education. AI used to standardize trainees' medical skills and knowledge, individualize the delivery and the practice of skills and knowledge. So, the adaptive radiology interpretation and education system has been developed. The trainee has to follow these icons by his provisional diagnosis, and the AI generates report for trainees' learning profile. AI can assess the trainees' performance over time by using 3 colors. Green color, the trainees who passed, means the trainee who passed the threshold and review to move on the next task. A yellow color means that the trainees who improved but didn't pass the threshold can practice. Red color means that the trainee who didn't improve can learn why and repeat the task. Also, trainees can review their personal AI reports and check the strength points. For example, distinction between high or low-grade glioma, and check the points and the areas which need improvement, such distinction between medulloblastoma and ependymoma, for example. What is the future role of radiologists in AI world? AI medical imaging tools engender palpable concern for the future of radiology about threats in increasing automation to job security. However, previous experience with automation in medicine tell us different story, such what happened with automated ECG machines, which give us multiple false results. The threats of AI in the size of radiology workforce may be overstated. AI to augment performance rather than replace the radiologists are the most likely near-term outlook. Benefits of augmentation: improved quantification, reduction in repetition, and productive allocation of tasks to radiologists. In the longer term, our field is likely to be transformed in ways that are difficult to predict. AI is set to alter many different aspects of practice beyond diagnostic support. AI education will need to target learners of all levels, from medical students to senior practitioners. And thank you for your attention.
Thank you very much, Dr. Hala, for this interesting talk. Dr. Lawrence is ready with us now. I need to ask a question, Dr. Hala. This artificial intelligence will be incorporated in all aspects or all subspecialties of radiology, or it will be more available for certain subspecialties or certain topics?
Yes, no, artificial intelligence is a state of art in the whole world nowadays, not only in the medical field, but in all medicine, all fields, and in all medical specialties, in surgery and in internal medicine, in radiology. As I think it will pass in all branches of the radiology. The radiology is a field which very promising in artificial intelligence in the future.
You are expecting that the role of the radiologist will be minimized or will be
never never. He will help us. The computer will help us by the multi-parameters of the MRI, the 1,000 images. He will help me in interpreting this all information and give me a provisional diagnosis, help me in the equivocal diagnosis, help me in ER department for detecting rapid detecting of hemorrhage, or help me in helping the juniors for better performance, but never it will replace us.
Just augment.
Just augment and help and give us help and assurance for the diagnosis.
Yes. It is applied in this corona pandemic.
I think it will be beneficial in the pandemics where a lot of cases, a lot of images, and there's في ظروف الحجر وكده أعتقد إن artificial intelligence will help us very very much. But it is not applied yet. It is not applied yet. Unfortunately,
it's not applied.
No, still. We need we need some years to apply it in the clinical.
Yes. What are the topics that artificial intelligence has a main role now in, or helping role in diagnosis?
In whole the world or in Egypt?
No. In radiology.
Radiology.
What are the main aspects or main diseases or?
I think for detection of hemorrhage, rapid detection of hemorrhage in ER department, yes. Segmentation, and for radiotherapy planning, and post-operative follow-up. It will be this case is good candidate for AI help or support.
Yes. Will in the future, Dr. Hala, we need your support. We have assistant lecturer in our department now preparing a topic regarding this artificial intelligence.
It is a great honor for me, Dr. Hisham.
Inshallah, and Dr. Lamia told me also that Dr. Ayman Abbas can help us also. But
he is my professor, and he has many research topics in this topic.
Yes. Okay. Thank you very much.
Thank you, Dr. Hisham. Thank you very much.
Ustaz Ibrahim. Dr. Lawrence ready? Dr. Lawrence ready, Ibrahim?
Hey, hello everyone.
Welcome, Dr. Naju. How are you?
Let me get everything set up here. Can you see the presentation okay right now?
Dr. Naju, how are you? You are welcome sharing us in our teaching course or learning course for radiology department, Benha University. Dr. Lawrence is consultant at Duke University, USA. The talk will be about artificial intelligence in radiology. You are welcome, Dr. Nju.
All right, great. Thanks so much for the invitation, Dr. El-Sheikh, and thanks for the invitation also to the radiology department at Benha University. And then thanks also to Dr. Atef, who I think she's spoke very eloquently about some of the topics that I'll talk about here as well. To give you a little bit of background about where I'm coming from, again, my name is Lawrence Ngo. I've lived most of my life in North Carolina in the United States, where I did medical school. I did a PhD in neurobiology and a residency in radiology at Duke University as well. Currently, I hold several different positions at this point. I run a company that's called CoRead AI, which builds algorithms for radiology. Just as of note, there's a major disclosure that I would have to make, and also a lot of the companies that I might be talking about during this talk may be involved in us with business partnerships and things like that. So I just want to explicitly make sure that you're aware of that conflict of interest. I'll also plan on talking about in detail some of the work that our company does. So please, again, keep in mind the conflict of interest there. Clinically, I'm practicing radiologist as well. I currently do mostly emergency radiology with a company called Radiologic. And then third, I hold a faculty position, as Dr. El-Sheikh said, at Duke University. We collaborate on several research projects with them, and I'll talk about one of those today. I'm pleased to talk to you today about the state of AI, how it is doing currently, and also what the future developments are in store. I've structured this talk as a very broad overview, and I'm very happy to get into more of the details in any question and answer period at the end. So again, some of our previous speakers have spoken to this, so I won't spend too much time on this, but what exactly do we talk about when we're talking about artificial intelligence? So there's many different definitions, but one could be purely just replicating behavior that people associate with intelligence or cognition, replicating that same process in machines. Outside of radiology, there's a lot of examples of this. People talk a lot in the news and in general about AI being used to do self-driving cars, using AI to predict the stock market, or even to get, there's even AIs when you call customer service for anything that they use to detect the emotion in your voice, for example. So AI is, quite prevalent these days. This kind of activity, this replicating of human intelligence and cognition is a very clear interest because of its ability to produce tremendous economic benefit. That certainly has progressed much more outside of radiology than currently in radiology, but we're starting to see a lot of progress in radiology as well. And at the same time, as much promise as it holds, as you mentioned in the previous Q&A, it also comes with a lot of great concern as well, because with its benefits, it may also disrupt the labor market across a lot of different fields. There's a lot of different related terms when we talk about artificial intelligence. And so just to kind of provide a framework for what people are talking about when they talk about these other terms, there's also the term machine learning and also deep learning. One way to conceptualize the relationship between these three different terms is in the following diagram. As I said before, artificial intelligence can be viewed as replicating human behavior using computers. Machine learning can be a subset of this, where algorithms are designed that can find patterns in data. Many researchers have actually been using machine learning for decades. You might not, if you do research, for example, you may realize that some of the statistical techniques that you use, even the simple ones like logistic regression, fits under the heading of machine learning. And finally, there's deep learning, which is a set of techniques within machine learning that use neural networks. A lot of the excitement more recently within artificial intelligence and machine learning are due to advances in deep learning. However, researchers and others have been using machine learning, as I mentioned before, for quite some time. So the within the medical field, and particularly in radiology, you may be familiar with some of these previous developments, especially in machine learning. So computer-aided detection, or CAD, has been around in radiology for a long time. For example, the FDA in the United States, they first approved computer-aided detection for mammography back in 1998. That's almost 23 years ago. So the initial adoption of CAD at that time wasn't high, but it really increased after the government in the United States ended up reimbursing for higher rates for exams that included CAD as part of the processing. However, speaking anecdotally to those who have used that technology, the overall utility of the tool was quite limited. I don't know if people in the audience have used the tool directly themselves too. Further, there's ultimately a lot of systematic studies that showed that CAD did not increase mammographic diagnostic accuracy. And so I think there's been a challenge with its adoption and also its business case. As I mentioned before, the subset of machine learning called deep learning has had some more recent advances. So that have really increased the accuracy of a lot of these algorithms. And that's part of the reason why we're hearing so much more about this next generation of artificial intelligence algorithms being applied specifically to radiology. A big part of this advance has been the exponential rise in the amount of data that's available. It takes, this is kind of a shocking figure to me. It takes only about 2 to 3 months currently for the total amount of medical data in the world to double. So the doubling time is just a couple months. And so within a year, we have many-fold greater amount of data than we did when we started the year. And the average radiologist, which you may also experience in your own radiology practice, can expect to interpret tens of thousands, maybe even 100,000 images per day, especially if you're scrolling through many 3D data sets, CTs and MRIs. And the same figure for just a couple decades ago, 10 or 20 years ago, you might interpret only about 100 or a couple hundred images a day. Even with that said, with all this new data, there's still many challenges with this new generation of algorithms, and we'll get into that a little bit more. There's issues with the generalizability, and there's also the issue of applicability to the overall radiology clinical workflow. It's made it very difficult to generate a good business model in order for universities or companies to develop these algorithms and distribute them. And as you may be aware, it takes a lot of work, a lot of resource, and a lot of expense to develop these algorithms. So there needs to be a viable business model in order for them to continue to proliferate. So thinking about how this technology will further mature, there are certain things that AI algorithms currently do that they're currently good at, and then there are certain things that they're quite bad at this point. Overall, AI performs well when a problem is clearly described and circumscribed. So for example, if the task of an algorithm is to detect the letters of an alphabet, then it tends to have quite high accuracy. This is something that people in the field have been doing for quite some time. This kind of task has been done before the deep learning revolution, and furthermore, when there's a very clear, small kind of problem. Additionally, the problem can be a little harder than just character recognition, but when there's a clear measure of success, the algorithms are also able to be designed and optimized and be able to even improve significantly above human levels of performance. Take one example, which is chess, where I don't know if you remember, but back in 1996, IBM created an algorithm called Deep Blue, and it was able to defeat the world chess champion Garry Kasparov. And more recently, what people often think to be a more difficult game of Go, Google was able to create an algorithm called Alphago that was able to defeat one of the leading, the top players in Go in the world. Both of those games have very well-defined rules to the game. And again, when the end goal that is desired is very clear, then these algorithms tend to do quite well. However, as you may know, real life is not so well defined. The rules aren't as well defined. And so when we try to go from the laboratory with kind of toy examples and go into the real world, we run into issues. These algorithms tend not to generalize as well, and there are a lot of more factors in terms of changes in the environment and other unexpected factors. And additionally, sometimes the goal of what we're trying to program these algorithms to do is not even well defined. So take the example of self-driving cars, which I mentioned earlier. If you define something a little bit better, like driving on highways where the road markings are clearly defined and the behavior of the traffic is relatively regular, then self-driving algorithms tend to do quite well. But when it's forced to navigate a very busy, some busy city streets or even a parking lot, you have to have much more context about what other people are intending to do in the parking lot, if they're pulling out, if pedestrians are going to cut in front of you. And then furthermore, there aren't even road markings on the road. So a lot of this makes the problem much more difficult to handle. When we turn specifically to radiology, some tasks in radiology are also quite regular, so they tend to lend themselves to being improved with AI. So I've mentioned just a couple categories here. There's much more beyond these three categories on how AI is being used in radiology, but I'll focus on these three. One of the biggest ways currently, which AI is currently being used, is triage. As you know, in many clinical settings, there's a long time between the time of scanning the patient and the time that a radiologist is able to look at the images and render an interpretation. In many of these cases, there can be life-threatening conditions that require emergency intervention. Artificial intelligence can be used to analyze these exams as soon as they've been scanned from the scanner. And they can use the outputs from these algorithms to reprioritize work lists so that radiologists can read studies with emergent findings like intracranial hemorrhage, for example, sooner than those without these emergent findings. There are several companies and several radiology practices that engage in this kind of workflow modification. The practice that I work for is one of them. And it's been a decently successful business case in terms of providing benefit. You can actually take it into a slightly different direction. You can take the results of the algorithms and push the data to someone who might not be a radiologist directly, so potentially an interventionalist. Perhaps the most popular example of this is in large vessel occlusion for stroke on CTA, where during a stroke code, you can send some of the data from the angiography straight to the neurointerventionalist. And so they can basically review the data on their phones, access the images and decide and get ready for an intervention sooner rather than later, especially in a context where time is very sensitive. The case for triage can also be used in kind of the non-emergent setting too. There's a lot of different ways you can use this. For example, you could use an algorithm to analyze a large group of mammograms to decide which ones warrant more immediate diagnostic workup before the patient ever leaves after their screening mammogram. Such a system could reduce the number of callbacks, and there are some hospital systems now with and without the use of AI trying to experiment with just doing one-day screening, quickly look at the image, and then if there's something abnormal on the screening mammogram, go ahead and get the patient to do diagnostic workup and potentially biopsy and the rest of it too, all in the same day. At least the standard in the United States right now is that's 2 different steps. You do screening on one day, and then you'll hear back from the radiologist, and then you can do additional workup in the future, which can reduce a lot of the efficiency of the overall workflow. And it produces a lot of patient anxiety as well, as you can imagine. So beyond triage, another application that in radiology could be quantification as well, which is something that radiologists do to some degree, but it can be difficult depending on what type of quantification we're trying to do. It can be quite time consuming as well. So perhaps the most common example of the use of algorithms to in radiology right now, at least in the practices that I've practiced at, is the fractional flow reserve for cardiac CT. It's this algorithmic measure of the degree of significance of occlusion in the coronary arterial tree that may warrant intervention or not. And there have been studies that have shown that there's high correlation between invasive measures and the algorithmic measures that are just derived from the CTAs. And so that's quite common, and it's reimbursed nicely now too, at least in the United States. And so that's probably one of the more common uses of quantification, but obviously there's a ton more examples on the market. And then you can also do something that's not potentially just specific to just one patient, but you can do something that's more applicable to population health too. So there's some companies that are trying to apply radiology AI into radiology, where they can look at overall population measures of, for example, hepatic steatosis or osteoporosis, and be able to derive insights across a whole population instead of just one patient. As you can see, that at least on the commercial side, there's a lot of different companies that are quite well funded. Honestly, investors are very excited about this field of radiology and AI. And there's a lot of very talented people working on interesting problems. I mentioned some of the triage stuff earlier. AI Doc's probably one of the leaders in that realm, trying to prioritize studies for quicker interpretation. Let me see if I can highlight here. So VisAI is another company I mentioned. They do a lot of algorithms, but they have a large vessel occlusion algorithm that helps to prioritize intervention. Another company, which again, for disclosure, that we have a business partnership with, RadAI. They have a slightly different approach to it, which is also interesting to think about. They actually currently, their main product has to do with not anything to do with the images themselves, but what they do is after, let's say you're dictating a radiology report and you dictate all the findings, it'll use AI to analyze those findings and automatically generate an impression. And so they've shown in some studies that that's able to improve turnaround time and increase the efficiency of radiologists. So as you can see, that's just 3 of them, but there's obviously a ton of excitement in the field. I'm going to just shift gears a little bit and make sure that you're aware that, so this is related to our company. Again, I'm a founder of this company, and so I do have some financial interest in this, but it's the topic that I know best about what we're doing. So I'll just talk a little bit about what we do. So the company, again, that I work for is called CoRead AI. We deal with trying to improve quality in radiology. And so in the United States, the problem of medical error is quite a big problem. One is probably 5 to 6 times more likely to die of a medical error than a car accident. And there are some estimates, these estimates vary widely, but there's one estimate that around 250,000 patients die in the United States annually due to medical errors. Now, the medical errors span, it's not just radiology. There's obviously many other fields and many other contexts in which errors can occur. But radiology does form a cornerstone of diagnosis within the field. And again, as radiologists, you're quite aware of how mistakes in radiology can negatively impact the patient. And so we've built a system that is basically AI-driven quality assurance. I guess before I get into our workflow, I'll describe what quality assurance looks like in the United States currently. So the American College of Radiology, which is an accrediting body in the United States, it requires every radiology practice to have a quality improvement program in order to be accredited. And as part of that quality improvement program, radiologists have to do what's basically a second review of some of their colleagues' reports. There's a system that's widely adopted. It's called RadPeer, where you can provide feedback to other people in your practice about the quality of their reports. This can range from total, agreement about, the interpretation for a CT scan, or it can be disagreement saying that, your colleague missed something that was quite serious. We tried to, the problem with the current process is that it's really inefficient. In general, radiologists are quite good. We estimate that the rate of major mistake among radiologists is about 1 in 1,000. And so if you just randomly review cases that your colleagues have interpreted, you would have to review nearly 1,000 cases in order to find a major mistake by them. And so that takes a lot of time. It's very costly for practices to have radiologists reviewing other radiologists' work instead of just doing the clinical work and providing more, revenue that way. And so what we've done is we've leveraged some of our AI algorithms to make this this process a little bit more efficient. And so the way that works is that we have a vision algorithm that looks at a medical image. We have another algorithm, which is natural language processing, which looks at the radiologist report. Again, this is done after the radiologist has already interpreted the study. And then any discrepancies, any differences between what our vision AI algorithm said on one hand, and what our natural language processing algorithm said on the other hand, if there's any difference between the two, then we flag that study for a QA process. So here's an example. So this is a real life example. It's a CTPA on a patient with COVID-19 pneumonia. As you can see here, the patient's condition was actually complicated by pulmonary embolism. However, the interpreting radiologist was, I'm not sure why, but they were potentially too distracted by the pneumonia or some other things. And so you can see the radiology report here. They actually missed the pulmonary embolus. And so, again, this is a real life example where our algorithm was able to detect the pulmonary embolism on the images. And then our natural language processing algorithm was able to see that in the report that there was no diagnosis of pulmonary embolism. This study was then flagged, and then that was then sent to the QA committee. The QA committee then agreed with the interpretation of the AI, and then was able to notify the initial interpreting radiologist about the mistake. And also we're speeding up the process now where we're able to do this quickly enough where we can actually addend the report and change the patient management based on the difference in diagnosis. We're currently running live on a system in a teleradiology practice that serves over 2,000 hospitals in the United States, and we're currently finding about 1 to 3 missed pulmonary emboli a day using this system. So we're pretty excited about where this is going to head. And then we did an independent validation of this workflow at Duke. This was a retrospective analysis that we published in JACR, and you can see that we analyzed around 11,000, close to 12,000 CT exams, single phase CTs over a year. And this included both abdomen pelvis exams and chest abdomen pelvis exams. After all the exams were run through our algorithm, both the vision and the NLP algorithms, we were able to flag a certain number of studies that then radiologists were able to adjudicate, able to review. And in this retrospective cohort, we were able to find 79 incidental pulmonary emboli that were correctly reported. However, by using the artificial intelligence algorithm, we were able to find an additional 49 cases where pulmonary emboli were missed. And again, this is at a major academic institution where often a lot of studies are read by more than one radiologist. It's often read by a resident and then an attending. And so even after multiple steps of review, we were able to find 49 major misses. And so our conclusion is that artificial intelligence can efficiently analyze these scans, and they can be interpreted for potential, life-threatening mistakes. And we think that this is an exciting direction moving forward in applying AI, especially in its current state, at its current level of capability, and providing some benefit to the overall workflow. So taking a step back away from what we do at our company, I think there's a lot of concern about, within the field of radiology, about how artificial intelligence can threaten the labor market. One concern is that one day these algorithms may be so accurate and relatively cheap that health systems may no longer want to employ human radiologists for a lot of these tasks. And I mean, human radiologists, they're very expensive to hire, but they're also very expensive and take a very long time to train. It takes many, many years to become a good radiologist. However, as I've described in the use cases so far, it looks like radiologists are still very much within the workflow. What AI is currently trying to do, and you mentioned this in the previous talk as well, it's very much trying to augment the work of the radiologist as opposed to replace it. There's a leading figure in the field of AI, and you may have heard of his name, Jeff Hinton. His work, his research was one of the major milestones in what got deep learning to really take off in the last couple of years. And really in the rise of artificial intelligence outside of radiology, just in general. That's why everyone's so excited. It's due to a lot of his work. In 2015 at a conference, he said that we should just stop training radiologists right away. And the reason for that, he said it was very clear that artificial intelligence would be better than radiologists in 5 years. And there's just no more point in training additional radiologists. So I was looking at the date of that as of just a couple of days ago, like 3 or 4 days ago. It's been exactly 6 years since he made that prediction, and he said 5 years. So we're already 1 year behind schedule. And so I think that, again, I'll admit this myself. I run a company that depends on building the best algorithm possible. And I think that even then, we're still a very long time from getting these algorithms to perform at a level that could threaten the jobs of radiologists. And additionally, there are other reasons why radiology as a field will not undergo significant transformation in the short to medium term, at least not transformation in the replacing aspect, in the replacing sense. The demand for radiology continues to increase quite steeply, and especially in the United States. I'm not sure about in the rest of the world, but there's quite a labor shortage, and unlike in other industries, it's very difficult to deal with this labor shortage because it takes many, many years to train radiologists. And so the prediction among most experts is that artificial intelligence will change the way we do radiology. It might allow us to do more precise analysis and potentially take away some of the mundane tasks that, and potentially free up our time to do some other things, whether it's patient interaction or reading more difficult studies or more complex studies due to increased bandwidth. But there's an overall consensus that there's no current threat, especially given how behind schedule I think we're going to be based on Jeff Hinton's prediction. There's another quote, I think it's attributable to Bill Gates, where he basically says that people tend to grossly overestimate what can be accomplished in the next 1 to 2 years, but potentially underestimate what can be done in the next 10 years. I think we're still in that early stage where a lot of, or maybe we're getting just past it, but for a couple of years there, I think we were in that early stage where the predictions were very aggressive and were grossly underestimating what was going to be possible to be done within AI and radiology. But again, I think I do believe in the second part of that quote, which is in the 10 to 15 to 20 year time frame, I think there's quite a lot of transformation that can happen. And I think we just have to temper the aggression of some of the predictions of what AI can do. And a big part of, I mentioned why some of these projections can be behind is I think people outside the field don't realize how complex radiology is. Certainly there's a lot of image interpretation that goes into the job, but even the image interpretation itself can be quite complex, not straightforward. There's many times where I have to discuss with colleagues about difficult cases. And I mean, that's just a very common occurrence on any given day, any of my clinical days. And apart from the image interpretation, there's stuff that's outside the image interpretation that's not quite straightforward. It's really difficult to program algorithms to how to deal with, different scenarios where there aren't defined rules. So as I mentioned before, Jeff Hinton pointed out that radiology in particular was going to be replaced, but it seems like radiology has been such a target in the general discussion about AI. Certainly the data that's recorded in radiology is quite large compared to other fields. You can say that maybe within internal medicine, history and physical isn't quite as rich of a data set that's being provided as some of the sophisticated machinery that radiology is able to leverage to produce very large amounts of data. But I think many other fields in medicine are basically in the same situation that radiology is as well. And I just think people don't quite realize it yet. Just like any transformation that may happen in radiology, I think those same developments will augment the workflow and not necessarily replace them. And one example, I think the most extreme example is probably in psychiatric or mental health. People might initially predict that that's probably the last thing that might be automated by AI because it's so difficult to be able to program an algorithm to understand all the intricacies of human conversation, human emotions, things like that. But that's actually one of the leading fields that companies are working on to try to apply AI to. I think the reason for that is there's just an immense lack of access to mental health services within the field. So again, many companies working on this, and the goal of these companies is really not to try to be better than a human psychiatrist or therapist. They just need to be better than nothing, because that's what many patients in the world currently have access to. And so I think that certainly radiology, but the rest of medicine too, is going to be impacted by AI significantly. I think there's a little mention of this in a previous talk as well. But when we have poorly defined problems, there's the problem of integrating our value systems into these algorithms. So for example, let's say you're reading a CT scan on a 90-something-year-old and you are able to see an incidental breast nodule that you think might need a mammogram. And you can change that age to whatever you want, 90 years old, 95 years old, 70 years old, whatever the scenario that fits best for your framework. But there's a lot of different society guidelines, you know, for lung nodules and renal lesions, but certainly not as many for incidental breast lesions. And so when you have a lack of guidelines, a lack of rules, how do you program an algorithm to decide what to do? I think currently for those situations when a human radiologist is involved, we just use our own judgment about what we think, you know, would be most helpful to the patient, most helpful to the treating team. But the threshold, even then, the threshold that different radiologists draw can be quite different. And it would be difficult to come to a consensus in order to then program these algorithms to do what we want the consensus to do. It's already apparent that such algorithms are difficult because of the lack of society guidelines. But in addition to that, you know, there's just very little consensus among outside the guidelines. So there's different ways to approach this. I don't know if there's quite a best way to do it, but maybe one could take a cue in the future from what RadAI is doing. The company that I mentioned earlier that analyzes the findings and then generates an impression. You could potentially get an algorithm to analyze your practice pattern, an individual, like as an individual radiologist, how you tend to call incidental lesions at different ages. And you could potentially train an algorithm to then just follow your own practice pattern. And so that means then there would be a different algorithm for every single radiologist. And that can provide some difficulty in terms of, you know, generalizability and uniformity. But at the same time, that could be a way in which we could address some of the issues where, you know, we have more difficulty with applying value systems in particular. And then, especially in the United States, I'm not sure what the situation is in Egypt, but medical malpractice liability is a hot topic in the United States. The question always comes up as to what to do with the liability when an artificial intelligence algorithm makes a mistake in the medical context that could lead to the harm of patients. There's a problem that we've had to deal with in our own company when we negotiate a lot of our contracts. And honestly, it's a very difficult thing to negotiate and to try to figure out because the first cases of this have not even been entertained in the courts yet. So no one knows quite how the American court system is going to deal with the situation. Is it the company that builds the algorithm that should bear the responsibility? There's certainly precedent for this in the past where, let's say, a company produces artificial heart or LVAD. So in the case of implantable hardware, it seems like the medical device company would be liable for any flaws in the design of the device. And if it leads to patient harm, then they would be on the hook for it. But alternatively, could it be the hospital that's that deployed the artificial intelligence algorithm that's liable? This could be especially relevant if the hospital is the one producing the algorithm in the first place. And currently in medical malpractice, there's a lot of examples of like the cases basically involving the hospitals because they tend to have you know, the most money available for the litigation. And then certainly there's an argument too that maybe the liability ultimately falls with the radiologists, especially the way that radiology practice is done today. The radiologist is the one supervising the artificial intelligence algorithm. And so when they do the final, you know, signature for the report or whatever, it's their medical judgment, their diagnosis, and ultimately their responsibility. And so could it be potentially the radiologist who's liable? We're actually in the process of discussing with many people in the field, and we're organizing some studies now where this whole situation to the radiologist might actually be a little unfair because the algorithms that produce these outputs might actually unknowingly bias the opinions of the radiologists. So they may actually sway them to make more mistakes in certain ways than they would have in without the AI context. And so in a case where the algorithm is biasing them, the radiologist may be handicapped. I guess is what I'm trying to say in certain contexts in terms of being able to avoid mistakes. There's a recent study last year that came out that showed that if you provide AI advice, especially to radiologists who have less experience, like residents, if you provide bad AI advice to them, then they tend to follow the bad advice more often than to reject it. And that was in the context, I believe, of chest X-ray diagnosis. And so it's something to think about as we move forward, and something that needs much more further study as well. And then finally, there's the issue of artificial general intelligence. And so loosely defined, artificial general intelligence is the ability of machines to understand the world and interact with the world much like a human does. This goes across many different domains. So instead of just having, for example, an intracranial hemorrhage algorithm or a pulmonary embolism algorithm, an artificial intelligence algorithm could do a wider span of tasks that span across all the skills of a human. So it really could just do anything a human could. This would be deeply transformative to society, since presumably any job that a human could do, a machine could do as well. However, this brings obviously much more deeper and troubling questions as to what we do with job markets and what we do with equality as well. Potentially there would be a lot of inequality generated by people who have access to money, who can afford to use such algorithms to generate more and more revenue for their business using these algorithms, and then those who don't. And so I think most predict that this is still a long way away, and there have to be some major breakthroughs that we just don't know what those breakthroughs will look like yet, and for this to become true. Some believe it might never even happen. I'm not sure exactly how soon it may come. I guess my approach right now is that I think that in the opposite of general artificial intelligence is narrow artificial intelligence, where you just train algorithms to do specific tasks. And I think that's probably a higher yield thing to focus on at this point. At least that's what we focus on in the short to medium term. And I think that even before we have general intelligence, there can be great benefit to society, but also great risk that I mentioned before too. So we have to be careful, and we have to be thoughtful about how we adopt a lot of these technologies. So for the contents of this presentation, I'd like to credit several people. In particular, he's actually a philosopher and a former mentor of mine, Walter Sinan Armstrong, and computer scientist Vincent Konitzer. For the contents of this talk, several years ago, we did a panel discussion for another grand rounds at Duke, and I drew on some of that material for the inspiration for this talk. And again, I was very broad, and I did not go into much detail on any particular topic, but I would be more than happy to answer any questions that you have about any of the topics that I mentioned, or just anything in the field in general. Thank you for your attention.
Thank you very much, Dr. Lawrence. There is any rule right now for artificial intelligence in teleradiology?
In what? I'm sorry?
In teleradiology.
Teleradiology, yeah. So the company that I work for now, both clinically, but also we have a business partnership. So again, another disclosure with my company and theirs. So we are currently providing our pulmonary embolism algorithm to them for several different purposes. One is just general research purposes. One is for triage too. So if if a study is scanned and it might potentially take 3 or 4 hours for a radiologist to read it, our algorithm will actually flag it if it's positive for pulmonary embolism, and a radiologist will read it much sooner than that. But the use case that we're much more excited about is the quality assurance one, which I mentioned in this talk. And so currently we're running our algorithms across the whole practice, which is, again, it's over 2,000 hospital sites. Each month, it's more than 60,000 or more CT examinations. And every day, we're able to find about 1 to 3 mistakes that happen across the practice. This is no higher than rates of misdiagnosis that we've seen in other practices. If anything, it's probably lower. But again, it's a large scale practice, so we're able to find these mistakes. And again, it goes to their QA committee. They're able to turn these results around quite soon. And I think a lot of our hospital sites that we serve are quite aware of this workflow now, where we might be able to find some mistakes and be able to correct some of the mistakes that we make as radiologists. I think teleradiology in particular provides a really unique opportunity for AI, and that has a lot to do with generalizability. So, for example, if you try to generate an AI algorithm using data from just one hospital system, you may be quite successful in generating good accuracy, and even if you do validation if you do a test set validation separately. But the problem is that as soon as you go to a second hospital and apply your algorithm, a bunch of different factors may contribute to your algorithm completely failing. I think there's a lot of examples of that in the field. And so one example, one huge advantage for teleradiology is that if you train algorithms from the data set from teleradiology, which is from many, many, many different hospitals from many different geographic locations, your algorithm could presumably be much more generalizable when you go to a hospital system that's outside of that system, that network of teleradiology practices. So that's something that we have seen has been beneficial for the training of our algorithms. Again, we train using the data from this teleradiology practice. So every time we go to a new practice and install our algorithm, the performance tends to stay decently high. And so moving forward, I think it would be great there's public data sets that are available for pulmonary embolism, for example, for intracranial hemorrhage, that draw from about 5 or 6 different hospital systems. And then more and more in the future, I think it would be nice to even get more data diversity in the data that's being used to train these algorithms. And then the other thing is just scale too. The practice that I currently work for, it's more than 500 radiologists. I think the last count might be like 800 radiologists or something like that. So it's difficult if you have a small practice, like 4 radiologists, to be able to dedicate the technical resources in order to implement AI. And for better or worse, some of these AI solutions may be more cost effective when the practice is larger.
Dr. Lawrence, does artificial intelligence need a major change in the construction of the radiology machines like CT or MRI, or the available machines now? We can apply artificial intelligence on these machines.
So I'm sorry, I'm not sure if I understood the question. So CTs and MRI machines, are you saying are you asking where the artificial intelligence algorithm can be implemented? Like if it can be tied to the machines themselves, or could you?
I'm asking in the future, this for
okay.
applying this artificial intelligence.
Right.
This means a major change in the construction of the machines like CT or MRI or.
Right. So currently, with our company, we focus on CT. There's other companies that focus on MRI, and then there's others that focus on plain films and nuclear medicine too. In the future, it's conceivable that you could generate more complicated data sets that the AI would be more able to process than humans can. So for example, let's take MRI. I imagine that MRI scientists can come up with many, many sequences that might look like, total, complete noise to a human. Maybe they can even present, the case-based, representation of the data straight to the AI algorithms. And potentially there could be signal there. I know that, and then in the future too, obviously like dual energy CT scans, some of the other advanced, technologies could be processed with AI to a great degree as well. I think one problem that we face when we move forward with this is that once we get into that domain, the outputs of the AI become much less understandable. Right now we have the advantage because if we get it to process on data that we know, so whether it's chest X-ray or CT scan, we can second review it and we can see whether it made a mistake or whether it did something correctly. And that's our advantage right now in terms of explainability. But in the future, maybe the modalities will evolve to be even more effective and take in more data. But I think at that point, it'll be more and more challenging for physicians in general, but radiologists in particular, to potentially understand what's going on with some of these data sets. And so, yeah, it'll be interesting to see how that evolves over time.
Some situations in diagnosis in radiology, like to assess the fetal lung maturity. This is needs many items to be diagnosed or to be suggested based on ultrasound findings. Can you suggest that artificial intelligence may have a role in these difficult situations later on, because this needs more complex data to make a decision like this?
Yeah. I mean, it's very difficult. Like, first of all, I guess my proposal and my approach has been to make sure that you have intermediary data points that you can still check as a human to make sure that you still understand that what the algorithm is doing is still reasonable. So I'll give you one example, which is a project that we're going to be starting soon, hopefully. So our current algorithm right now detects pulmonary embolism. So it's either present or absent. But there could be, and as you may be aware, there very severe pulmonary embolism. There's benefit for patients to get invasive intervention for invasive thrombectomy. Now, the severe cases are clear, but there's actually intermediary cases where there might be some benefit as well for invasive intervention. We're just not really sure yet. There are measures in the literature right now where you can quantify, and this is where a radiologist, we're not talking about AI yet, where a radiologist can quantify the amount of clot in the lung, amount of pulmonary embolism in the lung. And the way you do that is you count the number of vessels that are being occluded by the clot. And when you do that, you get a decent predictive measure about how the patient will, what the prognosis of the patient will be. And you have to add that to other measures that are more commonly used. For example, like, right ventricular to left ventricular ratio, things like that. But when you do this more time-consuming clot analysis, there could be some signal there too. However, the radiologists don't have any time to count all the vessels for every case. And also it's difficult to then translate a single number into, overall prognosis, especially without some defined system like they have in other fields. And so, we're in the process of trying to develop an algorithm to risk stratify patients based on their prognosis for pulmonary embolism, both in terms of their risk of dying, but also their risk of developing chronic pulmonary hypertension in the future, things like that. And by basically generating a prediction of risk stratification, if we don't have that intermediary, if it just gives us one score, it'll be very hard for us to confirm whether it's doing correctly or not. I mean, we can test it on a test set and it might be fine, but when we apply it to another context, we don't know if it's going to generalize well, and it could actually fall apart and we would never know. And so back to your question. So I guess our approach is, instead of just doing an end-to-end algorithm where we just take in the CT data and just generate the overall patient risk score, what we try to do is generate that intermediary too. So we also generate the intermediary where we count the number of vessels that are occluded. And so at least we have an intermediary data point so that we can understand what's happening, but also confirm that something that the algorithm is still performing like we expect it to.
You have mentioned that artificial intelligence augments the role of radiologists for diagnosis. But do you expect in the future that artificial intelligence will replace the role of radiologists in certain situations in radiology?
Yeah, I think it depends on the context. So are there going to be some cases where an algorithm will replace the radiologist? I think probably yes. So let me try to think of a good example. So I think a good example is probably bone age. Right now, the algorithms that produce the pediatric bone age are, quite accurate. And there was a recent study a couple months ago that showed that when you integrate that algorithm into the workflow, that radiologists are, the performance is actually improved. And there are probably some data that's showing now that the performance of these algorithms is actually better than humans. And so as long as there isn't some weird out of sample case where, as long as you don't submit as long as you submit a hand to it and instead of submitting some wrong data to it or something like that, I think that that's something that could potentially be automated relatively soon. I know from my own experience, if I look at a bone age, I'm not very accurate. I have to look at the book. And if I'm looking at a book, then I think that, the human skill level in that context is probably not quite good. I'm sure there's probably some pediatric radiologists who might be much better than I am. My wife's actually a pediatric radiologist, so I'll have to ask her. But in any case, I think something like that could be good for AI to do end-to-end potentially without supervision in the future. Another context that a lot of companies are trying to work on right now too is, what if we could actually identify studies that are normal and identify it with really high accuracy? So like a normal chest X-ray. is it possible where if the algorithm is 99.999% sure that it's a normal chest X-ray, that we don't need a radiologist to look at it? I think that some companies are looking into that and they're trying to do studies on it. And the data, I think, is getting better over time. So it's potentially, that could be another context. But overall, I think there still needs to be someone supervising at some point, because you never know when bad data gets fed into the algorithm, and you never know when the algorithm might start to underperform over time due to other cases. Oh, I think you might be on mute.
What are the current applications now, Dr. Lawrence, for artificial intelligence in radiology?
Sure. So I mentioned a couple. There's the triage case, which is helping to reprioritize work lists. There's the QA case, which is the one we work on. I'm trying to think of other cases maybe that I haven't mentioned. For example, there are companies that are working on post-processing of image data sets to make the images more interpretable, but also to be able to reduce on other factors, whether it's the radiation dose or the contrast dose, and be able to produce as high level of diagnostic accuracy or interpretability. There are companies that work on other things that are part of radiology practice, but not image interpretation. There's predicting the rate of no-shows for patients. So patients who don't show up to their appointment, try to predict that ahead of time and reduce the rate of that. That can increase, revenue quite a bit. There's also examples of companies that are trying to be more involved in research. So research studies, it's clinical research. So research studies often require very expensive image interpretation services, and there can be issues with uniformity. And so you can apply that in that context to provide, for example, measures of at least generalizable and consistent measures of emphysema across different patients, or osteoporosis, or sarcopenia. So I think and then there are the examples that, we've been using artificial intelligence for many years, and we may not just realize it. So the dictation software that we use is artificial intelligence. Every time we don't know something, we search for it on Google. That's artificial intelligence. So I think the use cases for artificial intelligence are quite wide.
Lastly, thank you very much, Dr. Lawrence. We hope that we'll meet again, inshallah, in the next sessions. We'll arrange later talk, and this valuable data regarding artificial intelligence. You are always welcome. Again, we need your cooperation with us on our next conference in next June, inshallah, conference of radiology department, benha University, and in our learning sessions that we always do every week. Thank you very much. Thank you, Dr. Lawrence.
Thank you for the opportunity, and it was great to speak to everyone.